want to apologize for our little hiccup in Illinois. As we all are experiencing here, we're trying to link together 3 different states, and had a feeling we were going to have our hiccup. So that's it. I think we're over it. So we're good to go. Want to welcome everybody this afternoon to the kickoff of the Midwest ALTO Project. My name is Adam Kohlrus. I'm Assistant Vice President of Quality, Safety, and Health Policy at the Illinois Health and Hospital Association. And I'm here in Naperville, which is a suburb of Chicago. We've got a handful of hospitals with us here in Illinois. We've got a few OSF hospitals, OSF St. Elizabeth Medical Center, OSF Sacred Heart Medical Center, OSF Heart of Mary Medical Center. We also have Palos Community Hospital and Norwegian American Hospital. So I wanted to real quickly see if we could test the other technologies in Wisconsin and Michigan and see what partners you guys may have in the room today.
Hi, Adam. This is Wisconsin Hospital Association. We don't have hospitals in the room, but we do have Fort Healthcare joining us online.
Great. Thanks, Shruti.
This is Dr. Nelson, and I'm with ProMedica Bixby Hospital in Adrian, Michigan.
Great, and I know on the screen we can see a couple of our subject matter experts, Dr. Redwood up in Wisconsin, who we're going to hear from very shortly. And we have Tran, our pharmacist lead, who's just about 30 miles away. Thanks for joining us, Tran. And so I'll go ahead and get us started. And I'm going to do a quick introduction here from the Hospital Association perspective. On the next slide, though, I want to take a quick look at our agenda. Over the course of the next 4 hours or so, you're going to be hearing from us on the project and what the design is. But really, we want to get to the meat of this. And so we're going to be rolling out our subject matter experts that have joined us in this effort to talk through the clinician, pharmacist, and nursing responsibilities that we're going to be tackling over the course of 2018. And then we're going to hear from our Michigan Hospital Association colleagues who are running the data and IT portion of the ALTO project. We're also going to give you guys some time to do some action planning. And I know there's packets and handouts in front of you that we'll go through in just a couple of seconds, but we're going to commit to still wrapping up and getting you guys out of here at 4:15 Central. And sorry, an hour later for those of you up in Michigan on the Eastern Standard Time. So on the next slide, this is a high-level overview of the Midwest ALTO project. So the goals and the aim are pretty bold, but they're straightforward. We're trying to reduce administration of opioid medications by ED clinicians through the implementation of this ALTO approach. And our aim is going to be a 15% reduction in opioids measured in morphine equivalent units in 2019. And so we're going to get into data a little bit later this afternoon, but we're going to be looking at prescribing patterns changing in 2019 and then comparing that data to what we saw in 2018 over the same time period. And so we're really adopting this approach, as many of you know, from the Colorado Hospital Association's Opioid Safety Pilot, which they ran in 2017. And over that course of time, they worked with 10 EDs, and they achieved a 36% average reduction in the administration of opioids in those 10 EDs over that time. So we're aiming for more than 36 because we always want to be better than our peers. But we're setting the bar at 15% here across our 3 states. So on the next slide here, I want to talk a little bit about project design. We obviously have a bigger challenge ahead of us in the Midwest ALTO project because we're trying to do this concurrently across 3 different states at the same time with subject matter experts that are spread across 3 different states at the same time. And Colorado worked with a closer, tight-knit group of hospitals on a very high-touch level that were all in the same state. And so we're being very ambitious here, but that's what we're excited about. We're excited about the challenge. And so our subject matter experts have already introduced Tran and Bobby, and you're going to hear a lot more from them today. Ashley Myers is our nursing subject matter expert, and she's based in Michigan. So we do have representatives from each of our states that are joining us in this journey. And we're going to have a variety of training options and materials for you guys. If you've already poked around in the Colorado Hospital Association's website, you've seen a ton of their on-demand content. We're going to use some of that. We're going to have a lot of our own But what we're going to aim to do is this fourth bullet point here is have these weekly implementation calls that are going to launch Tuesday, September 25th, and they're going to continue each Tuesday from 1 p.m. Central to 2 p.m. Central, all the way through December. And on those hour calls, we're going to have all of our subject matter experts present. So we're going to have our nurse, our pharmacist, our physician, and our data team, and we're going to block off some time to discuss how implementation is going at your sites and to discuss any successes or barriers that you're achieving in any of those 4 areas. But then we also are going to be able to offer you guys more high-touch support. Say if you have some questions that pertain specifically to nursing or to pharmacy, we can link you up with our subject matter experts outside of those hour calls. But we think it's important to have those hour calls each week so our project leads can work with us to keep you guys on task and to ensure that we're giving you all the support and expertise that we can provide to ensure that we're all going to be ready to launch and change prescribing habits come 2019. So on the next slide, that's a high-level project design, and this is kind of a macro version or vision of the phases of this. And we're right in the middle here of phase 2. So our first phase of this ALTO project was to recruit and educate members across our 3 states. And now, we're happy to have a handful of hospitals in almost each of our states that are engaging in this. And today is the kickoff. So it's our official kickoff of this. We're in the middle of phase 2. And phase 3 is going to be in 2019 when we actually start changing prescribing habits and you guys start reporting data to us. So again, data is a big thing that we'll get to towards the end of the day. But this critical step 2 phase of education, dissemination at the hospital level is what we're really going to try and work with you guys to embed over the course of 2018. And while we have that blueprint from Colorado, again, this is the first time we're running this in a tri-state fashion, so we so welcome your guys' feedback and comments to us and how we could maybe pivot midstream here to make things more of a value add. So we look forward to hearing that from you offline and on those weekly calls and as we progress, because we really want to do this in partnership with you guys. So the next slide here is just going to highlight some of the resources which are in front of you. You have some handouts. There's actually 5 things in front of you. One of them's not on this list that I'll mention in a second, but just going from top to bottom. So the project enrollment assessment. Whenever we roll a project out from the association level, we like to gather some critical information from the hospitals, which we think are better going to inform us and allow us to help you through this implementation phase. And so we've got a hard copy of that enrollment assessment. The Michigan team has put together this in a digital format. So it's an enrollment assessment that shouldn't take more than a few minutes of your time, but we'll get that critical information of who the team members are, what kind of EHR you're running, and some other more specific clinical questions that is really going to help us mold these implementation calls. So insofar as homework, we can all start a list. That might be the first little assignment. We'd love for you guys to fill out that enrollment assessment, which will be sent to you in digital format after today. The second bullet point is our project pre-launch checklist, and this is what you see a screenshot of on the PowerPoint here. And I think this is going to be a critical tool for you guys through this project rollout phase. What we've really done here is worked with all of our subject matter experts to walk through each person on the multidisciplinary team and outline what the roles and responsibilities of those individuals are as the months progress. And so we tried to get pretty prescriptive there of what we think action-wise your teams will need to do to ensure that this is rolled out. And a lot of this knowledge was gained from the experience in the Colorado Hospital Association. But we think this pre-launch checklist is going to be a good roadmap for you guys as this is rolled out. So as the day progresses and you hear from our SMEs, go ahead and leaf through that, make some notes in it. And again, we've got digital copies of that coming, but we think this will also be helpful as you disseminate this education to more folks at the ED once you go home. The third bullet point here is the project action planning document. And so that's something that we're building in time to today's schedule to do. You're gonna hear a ton of information over the next few hours. And once you're hearing that, obviously we have to localize that and think of how it's gonna be actionable when you go home. So we wanted to build in some time for you guys to put pen to paper and get your thoughts out now of what next action steps are most immediate for you, or other folks who may not be with you today that you'll need to loop into the team. So we're going to have some time built out for action planning, and that action planning document really mirrors the pre-launch checklist a lot. So we're trying to give you space to figure out how to map out how this is going to roll out once you go home. The fourth bullet point here is our clinical pathways sheet, and so I think this is in your packet. And this has been a document, again, that was adopted from Colorado, but that has input from our Illinois, Wisconsin, and Michigan College of Emergency Physician groups. And so we got a lot of local feedback on this before we created it and sent it out to you guys. But that's going to be kind of the blueprint of what ALTO means for some of those conditions and how we're actually going to change those prescribing patterns. Again, that's a document that we fully well know may evolve or change as we proceed, but we wanted to give that to you guys at the onset. And then the final document that's not listed here, but that you guys do have, is the Colorado Hospital Association's pilot report. And so they just launched that in May. And that gives you the overview of what Colorado was able to do over the course of 2017, which in essence, we're trying to replicate here across our 3 states. So that's just a good document to reference to any of your peers, folks who are wondering about the evidence-based nature of this, and just demonstrating to them that this has been done, it has been successful, and we're really looking to kind of replicate the process and spread it here in Illinois. Hopefully a year from now, we will have a nice, pretty report that mirrors that, has even better data. So I know that was a lot, but I wanted to kind of launch us off with some of those foundational components before we jump into the content. And we're going to have plenty of time to discuss here locally and across our 3 states. But with that, I think it would be appropriate for Dr. Redwood in Wisconsin to go ahead and kick us off and give us the why here, why now, and why ALTO of why we're all here today. So without further ado, Dr. Redwood, I'll go ahead and pass the ball over to you.
Hey, Adam, thank you so much. And thanks, everyone, for being in attendance. I'm just absolutely thrilled to be here. A little background, I am a full-time emergency physician, and I also have a second board in preventive medicine, which is the medical specialty of public health, and a master of public health. And so truly my passion is taking care of patients clinically in the emergency department. But as an emergency physician, you recognize that there are a lot of problems that you can't change in that moment, in that single patient encounter. And so it gives me a lot of enthusiasm and passion to step back with my hospital association role and look at aggregate data, look at the state of the state, look at what populations of patients are doing, and try to affect change in that manner. I really, really cannot stress enough how thankful I am that everyone's here with us today. This is the epidemic of our era. The opioid epidemic in the U.S. is unprecedented. It really is, in scale and in scope. And we'll talk a little bit about that during this introductory portion. Clinically, I cannot tell you how relevant this is to emergency physicians. If you talk to your physician lead on these projects, I'm sure their experience will echo mine. But just before this presentation, actually, I worked a Friday, Saturday, and Sunday overnight shift in my local ED. And each of those nights, we had an opiate overdose. Now, all the patients survived. I was, of course, very happy about that, but that's not always the case. Synthetic opioids like fentanyl and carbfentanyl are out there. We're using Narcan doses of 5 milligrams, of 10 milligrams, of 15 milligrams without resuscitating patients. And the problem only seems to be getting worse, unfortunately. Now, one thing I really want to give as a caveat, and this is for the quality people in attendance, the administrators in attendance, your emergency nurses, your emergency physicians, your emergency pharmacists should get a round of applause for being here. The ED is not a large part of this problem, to be honest. 4% of opioid prescriptions come out of the ED. 4%. But what we do find is that emergency providers are extremely passionate about this issue because we are the ones seeing the patients. We are the ones seeing the overdose deaths. We are the ones holding family members' hands when we're not able to resuscitate a patient. And so this is very personal for us, and we are here to be proactive and helpful in any way we can. Now, you probably have noticed in your home health system that the ED is kind of a microcosm of the health system as a whole. And so what I do think is important is practices that start in the ED often disseminate to the hospital. They become inpatient practices, they become primary care practices, subspecialty practices. We've seen that time and time again with other examples of care processes. We also see that the ED is central to systems of care. So think about STEMI, think about stroke, think about sepsis. So much care is actually initiated in the ED. And so we're very hopeful that by starting these care processes in the ED, we'll be able to disseminate them out to other healthcare environments. I don't want to belabor the point too much with the history of the opioid epidemic, but I think it is important to realize how we got here, just to put some of this in context. In 1980, there was a single article in the New England Journal of Medicine, Porter and Jick, and it was a now regarded as poorly done study that basically showed that opioids were non-addictive. It was retrospective, 12,000 patients in an inpatient setting. They didn't really follow people up, and they found 4 patients became addicted. It was bad science. It was also cited 605 times, mostly by pharmaceutical companies. So this article was sort of held up as proof that opioids were non-addictive. Purdue Pharma was the maker of OxyContin, which is delayed release oxycodone. And they were really bad actors in this epidemic. They are facing lawsuits across the country. They've lost lawsuits already for being contributors to the opioid epidemic. I don't want to choose heroes and villains here, but beach balls were thrown out on beaches with OxyContin logos on them, frisbees, swing dance CDs given to young people with the instructions, do not crush or chew on them, which is basically an instruction on how to get high. And so we had some bad actors here early on. We had goals being set by pharmaceutical companies where bonuses were tied to how many opioids were sent out into the public sphere. And so the more opiates that were out in the public, the more people got paid. It was truly a model of unscrupulous practice. I think people are going to be held accountable over the next years and decades. But it just kind of shows you the concerted effort to get people addicted to these medications. The VA hospital actually had a good faith effort to treat more pain. They were getting membership feedback that pain was not being well controlled. And so they actually started a campaign of pain as the 5th vital sign, also in the mid-'80s. Now, as a clinician, I cringe when I hear of pain as a vital sign. A vital sign is something that shows you're alive, and it should be objective, like blood pressure or heart rate. Pain is not a vital sign. It's a very subjective experience, and we all know that you can live many, many years in pain. Nonetheless, JCAHO took this up, and hospitals' accreditation was actually based on whether you were measuring the pain scale. Now, of course, as a patient, if your doctor is asking you to rate your pain on a scale of 1 to 10, and you say it's an 8, I think it's pretty reasonable to expect that your doctor, your APP, or your nurse is going to do something about that. They're going to treat your pain. And of course, we want to treat our patients' pain, but the expectations set by the pain scale really put us in a difficult position in terms of healthcare. Ultimately, what all this did was disseminate opioids into the world, into people's medicine cabinets. Just like people have a beer in the fridge, they have OxyContin or oxycodone in their medical cabinet. You know, it used to be just heroin. You do not have to see your drug dealer anymore. You can see your friend, you can see your grandma, you can find opioids in most households in America. In fact, there is a 1-to-1 ratio of opioid prescriptions for adults in America. And we'll get into some more statistics about that. But it really lowered the threshold for access to these drugs. And as we all know, the addictive properties were vastly understated. They are extremely addictive drugs. The side effect profile is profound, and the withdrawal symptoms are profound. So people have a very hard time getting off of opioids once they've started them. If you spend any time with people who are in recovery or who are suffering from addiction, or if you've ever gone to a Narcotics Anonymous meeting, the death cycle, the pattern of death for addicts is jails, institution, and death. And so there's little pauses in addiction where you're in jail for a while and you don't have access to meds, or you're in a hospital for a while and you don't have access to meds, but addiction gone unchecked leads to death. And so I know I'm starting us off on sort of a grim place here, but I'm really hopeful that we can infuse some hope near the end of this presentation, because you guys are the ones on the front line. You're going to be changing the way that Americans think about opioids, the way that prescribers think about opioids, the way that we use these dangerous meds in our societies. This graph kind of says it all to me. The longer you're on an opioid, the more likely you are to stay on it. So if you're only taking an opioid for a couple of days, that's a 1 in 20 chance that you'll be using it a year from now. But look at this. If you're given a 40-day prescription for an opioid, there is a 50% chance that you're still going to be on that prescription 1 year from now. And so the length of use is very predictive. Now, of course, this project focuses on actual opioid use in the ED, not on prescriptions. And we'll talk about this as well, but a lot of states are doing good work to reduce the number of outpatient prescriptions. But I think the ED experience is relevant because what we're seeing are people who are in pain for the first time. Maybe you broke your arm for the first time. Maybe you fell on the ski hill for the first time. We don't want that patient to get an opioid unless it's absolutely necessary. We're not saying not to treat people's pain, but we're saying to use opioids as rescue therapy because we don't know who's going to end up getting addicted. But this is a disease that does not discriminate. It includes the elderly, white, black, rich, poor, any social strata of society. And so it's really up to us to be gatekeepers of these medications and use them as sparingly as possible. Again, I won't overwhelm you with statistics, but let's run through the uniqueness of this as an American epidemic. And thank you to the Michigan Hospital Association for your data page on these statistics. There's a lot more if anyone wants to learn more about the epidemic. The U.S. consumes 99% of the world's oxycodone. As we mentioned, one opioid script is present for every adult in the country. In 2015, 19,000 Americans died of an opioid overdose. If you expand that definition to include heroin, the 2016 numbers are up to 42,000 Americans. What that means is that opioid deaths now exceed the death rate for motor vehicle accidents. And so, I mean, if you think about that, it's less safe to fill a prescription than it is to get in an automobile, in a sense. As a physician, I like to think about the number needed to harm. For opioids, it's 550. For every 550 patients who are treated with an opioid, one will die of an opioid overdose in 2.6 years on average. You know, as emergency physicians, we think about radiation. You know, all the time, I'm using this statistic. For every 3,000 head CTs that I perform, one patient will get cancer from the head CT. They won't die from cancer, but they'll get cancer. This is much more dangerous than radiation. And we've had these amazing public health campaigns about radiation use and gentle imaging. It's time to get serious about opioids as well. And of course, it's not just the patient in front of you. It's that patient's spouse, it's that patient's children, it's the neighbors down the street, because 50% of all opioid-related deaths, are actually not obtained from the prescription themselves, but from a family member. And so people know whose medication cabinets to look in. They know how to divert these medications. And it's up to us to get fewer of them out into the community. You know, the genie is already out of the bottle. It's tough work to cram it back into the bottle, but we've got a lot of smart people working on this. State and federal governments are throwing a lot of resources on this. And so I just commend everyone for being here today because this is our challenge. It's truly the epidemic of our era. The numbers are grim. It's everywhere. It's synthetics, it's heroin, it's natural and semi-synthetic opioids. And if you look in the year 2000, our death rate was 3 per 100,000. Now we're up there around 13, 14, you know, a 500% increase. Where is this graph going to go? The Midwest, unfortunately, is one of the hardest hit areas. There's a really interesting article called The Epidemic of Despair, and it talks about poverty in the Midwest, about income inequality, about the increase in mental health that's gone along with the decrease in jobs and the fleeing of good jobs in the Midwest, and the role that opioids have taken in comforting people. Addiction in the Midwest is rising at a more rapid rate than the rest of the country. If you look at this graph here, Michigan didn't report, but this is from the CDC, but Wisconsin and Illinois are both in the danger zone with a greater than 50% increase in ED visits for opioid overdose in 2016 and 2017. In Wisconsin, we had the ominous honor, the grim honor of being the nation's leader. So we had a 109% increase in ED overdose from 2016 to 2017. And I can absolutely tell you that that's been my experience in clinical practice. The overdoses are only ramping up. It's kind of uncommon to have a string of shifts without seeing an ED overdose, especially on the weekend. Now, this project isn't focusing on the already addicted patient as much. It's focusing on acute pain treatment in the ED. But I think it's important to mention, how are we attacking this problem? You have to not only prevent people from getting addicted, but you actually have to treat people who are already addicted. Well, the Midwest is not in great shape for that either. And I know that there's a lot of work going on here, so I don't want to discredit anyone. Actually, a lot of very dedicated people are working towards this. But the ratio of certified buprenorphine providers to opiate overdoses by state is particularly bad in the upper Midwest. So we don't have the capacity to treat the people who are already addicted, and the rates of people who are becoming addicted are greater than the national average. Where are we going to be in 2018 or 2019? Where are we going to be in 2020? It's up to us to bend the curve. Let's make this real. Let's make this local. Let's look at our states, okay? There's plenty of slides on your local Department of Public Health websites. I try to just choose a few telling ones. Looking at Illinois, in the last 4 years, the rate of opioid, or the number of opioid deaths has essentially doubled. And this graph is very close to what you'll see for other states in the nation. Illinois, like Wisconsin and Michigan, have been doing a lot to limit prescriptions. And so we're seeing the rate of prescriptions issued nudge down, and we're hoping that eventually that will help to curb new addictions. But right now, that rate of prescriptions going down is not nearly matching the rate of deaths going up. Michigan is not faring better than Illinois. If you see in the last 4 years, the rate of death has also almost tripled, and is vastly greater than the U.S. average. And I think Illinois and Michigan and Wisconsin were faring a little less well than Illinois, actually, and so all the more urgent for our states. And then it's interesting to look at actual numbers too. So that last slide was rates, but let's look at the total number of opioid-related deaths in Michigan. 1,762 in 2016. These are the last available CDC stats. So that's 5 Michigan citizens every day dying from opioid overdose. Vastly greater than the number of car accidents. In Wisconsin, nothing about us is unique, but we do have a problem with prescription opioids in general. In other states, we're seeing a little bit more of an effect from heroin and synthetics, but it's very much still the medicine cabinet in Wisconsin, which is why I think this project is particularly relevant if you're practicing in Wisconsin. And like Illinois and Michigan, we actually have a mandated PDMP here. And we've seen a 20% drop in opioid prescriptions in the last couple of years, which is obviously encouraging. But that is just one piece of the puzzle. And we're going to talk about the puzzle to curing the opioid epidemic and the ED's role in it. And it's not just about prescriptions, it's about use in the ED, it's about harm reduction, it's about treating the people who are already addicted. And so I'm very hopeful that this project will actually inspire other projects down the road where we try to think about this from a holistic manner. It's important to focus, and I think this is a great place to start our focus, but we'll see what other projects come out of this effort. These are the 4 pillars of care of how to address the opioid epidemic from the ED. If you are a public health expert out there, if you are an administrator out there and you think of a 5th pillar of care or a 6th pillar of care, please share it with us. But the current model is based on limiting opioid prescriptions from the ED, using alternative options for pain control in the ED, and then things like harm reduction and treatment of the addicted patient, and at least starting those processes in the ED. Those are things like naloxone prescriptions, safe needle injection sites, using methadone clinics and buprenorphine to try to get people off of these medications. Like I said, our project today is largely focused on preventing addiction on these upper portions, and obviously specifically on alternatives to opioids in the ED. We're going to take a pause here as we record these slides, and then we'll get into the nuts and bolts of the Midwest ALTO project.